Hi everyone, thanks so much for tuning in. My name is David Singh. I'm an electrophysiologist at El Camino Hospital in Mountain View, California. And I'm also CEO of the Melvin Scheinman Foundation. Our foundation is named after Melvin Scheinman. He's really one of the luminaries in the field, and we have been really fortunate to work with a lot of amazing people to help develop a sustainable EP infrastructure in partnership with local clinicians and countries around the world where access to that kind of care is not readily available, or maybe it's still emerging. And we've been really fortunate to work with some amazing people in places like Cambodia and Vietnam, Tanzania, Ghana, and many other places. And the work has been really just inspiring. So this channel is admittedly a bit of an experiment. I find it really valuable to talk through cases, and I wanted to create a forum where we could do that online. My hope is that whatever stage of training you find yourself in, that there's something in here that you find useful. If you do find it useful, it'd be great if you can subscribe to the channel. Definitely give me feedback, things that you like about it, things that you don't, areas where it could be improved. And if you don't like it, let me know that as well, because I could use my time, going fishing or doing something else. So with that being said, let's dive into the case. I had a really cool case that came through the lab this week that I wanted to share. Okay, let's get into it. So I call this case of the week, but just to be clear, I don't always have a case of the week. This just happens to be a case that took place during a week, and I thought it was, catchy to call it case of the week. But I wish I got cases like this every week, but many of you know that most of what we do in EP these days is just ablate pulmonary veins all day, which I'm not complaining about, but it's nice to get a case that makes us think once in a while. This case definitely made me think. So let's start. So this started actually in our office. This patient came in to see my partner, who noted that the patient was in a tachycardia, and the patient was just really complaining of feeling quite fatigued for several weeks, if not longer. So now if we look at this, we see that we have a narrow complex tachycardia. It's regular, and that's a pretty limited differential. And of course, the first thing we always want to do is look to see if we see P waves here, and I do see P waves. If you look in AVL and AVF, you can see this is a short RP tachycardia. It's short-ish. I mean, it's really to the left of the midpoint, but it's not inscribed, for example, on the QRS. But I'd still call this a short RP tachycardia. Now, looking at this, I just see one P wave. You always want to make sure there's not maybe a second P wave that's buried, where you'd start thinking about things like an atrial flutter. But I just see a one-to-one relationship between a P and QRS. So I would, think about this as an SVT. And when we have an SVT, the differential in EP is really quite limited. It's either AV-NRT, which can be typical or atypical. It can be an atrial tachycardia, or it can be AV-RT. And so then you want to look at the EKG to see if there are any clues that might point us in one direction or another. And one thing that I do notice here, if you look at AVF and potentially lead 2 as well, it does look like the polarity of the P waves is positive. So it's got an inferior axis, it's going toward the inferior lead. So what does that tell us? Well, in general, of the three things that are differential, AVRT and AVNRT both are associated with retrograde P waves. So what that means is that the P wave in the inferior lead should be a superior axis P wave, or negative. So based on what I'm seeing here, my guess going into this situation, we did ultimately take her to the lab, is that this is possibly an atrial tachycardia, which of the three that I've mentioned, AVNRT, AVRT, and AT, is the least common. And it's also pretty uncommon to see someone in what is potentially an incessant atrial tachycardia. So that was what I was thinking going into the case. Okay, so before I get into the intracardiacs, I just want to cover some nomenclature that can be confusing for some people. Well, not just some people, for lots of people, because we're often not consistent about the vocabulary we use in describing various arrhythmias. So I'll just give you my take on this. This is how I was taught. I'm not saying it's the gold standard, but when we're talking about atrial tachycardia, in general, you can divide ATs into either a macro reentrant atrial tachycardia, which would involve any large circuit in the atria, or a focal atrial tachycardia. And focal just tells you that the origin of the arrhythmia is arising in a small region of the heart. But the mechanisms for focal atrial tachycardias can be at least three things: enhanced automaticity, triggered rhythms, and then micro reentry. So that's an important distinction. Now, if you think about a focal rhythm rather than a macro reentrant rhythm, I'll just show you a map from a case that I did some years ago. But what you see on the left here is basically a wave front that's originating. This is basically the cavo-tricuspid isthmus on the medial side. It's a bit hard to see. It's a little bit better angle here, but you're basically seeing a wave front that's originating in one discrete area and then spreading outwardly, just like dropping a pebble into a lake. The point of contact is where the origin is, and then you basically see the wave front emerge from that point. And for any focal AT, that's the kind of map that you would expect to see. So now moving on to macro reentrant atrial tachycardias, the most common one that we are familiar with is typical atrial flutter. So on the left here, what you'll see in this biatrial map that I created of a typical atrial flutter, you'll see that there's a large wavefront that is essentially propagating around the tricuspid annulus. So this is both typical atrial flutter, and you could also refer to it as a macro reentrant atrial tachycardia. Now, one very important thing, just in terms of nomenclature, is that what makes typical atrial flutter typical is the fact that it's traversing around or circling around the tricuspid annulus. It doesn't have anything to do with the direction of the circuit. In this particular example, this is going in a counterclockwise direction. I'll use my pointer here. If you follow the wavefront, which is not active right now, you'll see it's going around like this. Let me show that to you. So you can see it's going around in a counterclockwise direction. So this is counterclockwise typical atrial flutter, and it's typical because it's going around the tricuspid annulus. Now, if we look at this image here on the right, this is also typical atrial flutter, but you can see that this wavefront is going in the clockwise direction. So both of these are typical atrial flutter. One is counterclockwise and one is clockwise, but they're both typical. So just to kind of refine our understanding of the nomenclature, within atrial tachycardias, you can have a focal AT, which is a single focus. That can be either triggered, enhanced automaticity, or micro reentry. And then macro reentrant ATs are either typical atrial flutter, which can be clockwise or counterclockwise, or atypical atrial flutter, which is every other circuit that is a macro reentrant AT that is not going around the tricuspid annulus. So atypical atrial flutter, again, any macro reentrant AT that doesn't go around the tricuspid annulus. So hopefully that clears things up. So it's important to understand these terms so that when we communicate, we understand mechanistically what we're talking about and what we're trying to communicate. Okay, so getting into the intracardiacs, you can see here I'm mapping with a multi-electrode catheter. In this case, I used Atrial. That's similar to HD Grid, if you all are more familiar with Abbott products. And you can see the patient is in a tachycardia, a short RP tachycardia, the atrial activation with the CS placed in a traditional location is concentric. And really the first thing I did since the patient was in TAC was confirm that the tachycardia is what I expected it to be, which was an SVT. And so the first thing that I do is make sure that even though I think going into the case it's going to be an atrial tachycardia, I don't want to make the mistake of overlooking the fact that it could be AVNRT or AVRT. So I start with just a very simple maneuver, ventricular overdrive pacing, and you can see that I've dissociated the V from the A. And although that's not definitive evidence that this is an atrial tachycardia, it's pretty good. Ultimately, you would like to get a VAAV response if you're able to demonstrate retrograde conduction of the AV node. But AVRT is out because the V is an obligate part of the circuit. And usually with AVNRT, you are able to get into the circuit with VOD. So this was good enough for me to confirm that I was dealing with an atrial tachycardia. The next step is then to create a map of the tach to understand really where it's coming from. And this was the map that we created, and I can tell you right off the bat, it's very different than what I expected. I expected to see, similar to what I showed you a little bit earlier, a focal tachycardia that had a very discrete origin with outward spread. And instead, what you'll see as I play this is there appears to be a fairly large circuit that, at least at some point, you see a wavefront that it's emerging here. And then you have this sort of line of block here. And you see it pivot down this way. And then you kind of lose it for a minute. And then it appears again on the other side of that line, which we can't see. The other thing you should notice here, I'm going to pause it, is there's a lot of scar. There's a lot of scar here, which I wasn't expected to see. And the question is, well, why does this woman have scar? I wasn't expecting to see scar, but now that I see it, the question arises, where did it come from? Well, it turns out, I still don't know fully, but after speaking with her after the case, I mentioned that, hey, there was a lot of scar in your heart. I was surprised. She said that she had a very bad bout of pericarditis in the past. So I suspect she actually had perimyocarditis. But the interesting thing is her left atrium, which I'll show you later, was pristine. There was no scar there. And presumably no scar in her ventricles either. Her EF is normal. So this would have been a perimyocarditis that really affected the right atrium preferentially. I guess it's also possible that she just has a right atrial myopathy. But again, the origins of that are a little unclear. So let me try and play this again for you here. I think the interesting thing is to see, if I come back here, I'm going to pause it. What you can see, you saw this area here that corresponds to sort of potentially a pivot point. And then when you look here, there's an area of scar on this side, an area of scar on this side, and then you see sort of a corridor that corresponds to this area of slow conduction. And this is a potential target for what might represent a critical isthmus in the tachycardia. So that map wasn't what we expected, but it certainly is something that we had to tackle. And now I'm going to show you some intracardiac electrograms. This is intracardiacs of the region that I was showing you earlier. Oops, I'll show you here. So this corresponds to having the optral catheter in that area that looked very interesting. What you can see is you're seeing a number of different signals. You have this sharp signal here that's higher frequency, and it appears actually mid-diastolic if you're using the CSS reference. So that's interesting. And then you have these other low-frequency signals that are quite fractionated. So just from an electrogram standpoint, that certainly looks interesting. And again, this was probably in the lateral RA, sort of in the crista region. I definitely made a note of those signals. And honestly, looking at my map, sometimes you'll see a map and it's very clear where you're supposed to burn based on the wavefront, you know. And in this case, we mapped almost the whole cycle length, but there was a little bit missing. So I wanted to be really sure that my ablation strategy was on target with an area that was in the circuit and that potentially could be an isthmus. So I went to entrainment. Now I know we don't entrain as much anymore because, you know, mapping has gotten so good, but I still think it's a very useful and important thing to do when you're trying to really understand the nature of a particular arrhythmia and finding a suitable target. So I entrained from that region that I showed you just a minute ago. You can see it up here. And what you can see here is one that we now know what the near field electrograms were, that would be these here, because we're capturing those, and the far fields are not part of that entrainment, or they're not captured, I should say. And what you see here is basically we have a PPI minus TCL of essentially 0. So I know that area is in the circuit, and when I add the fact that the electrograms look potentially mid-diastolic and fractionated, that is certainly a good target. And I also entrained from another area. I was trying to determine whether this was passive or part of the active circuit. And this appears to be part of the circuit as well. This is sort of in the region just adjacent to the coronary sinus, which is here. So when I entrained from here, you can see again, I'm capturing that area with a PPI of minus TCL of essentially 0. So this area was also part of the circuit, but that might not be the best ablation target. I thought this was a much stronger area to target initially. Then, just to be complete, I did entrain from the CTI, and you can see that the CTI is way out. So that tells me that in this particular case, the cavo-tricuspid isthmus was not part of the circuit. Okay, and so basically what I chose to do is ablate this region. Remember, this corresponded to sort of a zone of healthy tissue between two areas of scar. And what you can see while I was ablating in that area is the cycle length goes from about 320 milliseconds and it starts to push out to 345. Now, that could be a good thing. That could indicate that you're affecting the circuit. It could also mean that you're creating an alternate pathway for the wavefront to propagate. But we certainly like to see that we're doing something. We're affecting the cycle length. And that corresponds to burning in this region here. And then this was more clear on retrospective analysis, but if you look while I was burning in that region, what I now know is that we terminated that flutter. There might have been one beat where there was no flutter, but then there was another flutter that really looks quite similar, at least in terms of the activation pattern in the CS that starts again. Now, we, during the case, did not recognize this immediately. We later realized that the cycle length of this new flutter was actually quite different. It was a little bit longer. And so once we recognized that, and that's why it's so important to always be willing to go back to the drawing board. If things aren't making sense, we noted that the cycle length had pushed out. And what I did at that point was question whether we were still dealing with the same flutter, right? And in fact, we weren't. We had terminated the first flutter, but it terminated for such a short amount of time that it appeared as though it was continuous. In retrospect, like I said, I think it terminated and a new flutter basically arose almost instantly. So this basically was a flutter that had a cycle length of about 370 milliseconds. And what I did is I went back to the areas where I had burned and entrained from those areas. And now when you look here, the area that was previously concealed was now way out. So this area that I had burned, or the areas proximal to where I had burned, were totally out of the circuit now. And when I ablated from the posterior CS region, recall that area was also in. Now it's way out. So now I know that I'm dealing with a completely different circuit. Okay, so now I have this new flutter, and you'll note that now I'm referring to this as a flutter. Better stated based on what we were talking about earlier, it's an atypical flutter, right? Because it's not going around the tricuspid annulus, or at least the first flutter wasn't. So now there's another flutter, and I created a new map. And so what we see here, when I play this, is that there's an area of sort of early activation near the SVC. I'm just going to pause this here. You can see that area there. And then it kind of spreads down this way, and then on the other side, down on the septal side, and you see this very large area of scar here. This is the right atrial appendage, which is essentially scarred out. This is the area that was previously ablated. You can see that was pink before. Now it's scar consistent with where we burned. And so let's look at this from some other angles. Again, we didn't have the whole cycle length. We got a fair amount of it, but not everything. And based on this, it wasn't clear to me where to burn. And when I saw the fact that there was an area of, obviously in a reentrant circuit, early is just somewhat arbitrary. But, one possibility is that this was actually coming from the left atrium and coming across Bachmann's bundle, and then the entry point, into the right atrium was here. So then I thought, well, maybe we haven't mapped the whole cycle length. Maybe this is now a left atrial flutter, so I elected to map the left side. Okay, so now what I've done is I've created a biatrial map. So I mapped the left side, and then I put the two maps together because I wanted to see, looking, maybe it's a biatrial flutter. So I want to try to understand the relationship between the left atrium and the right atrium, and you'll note that this area remains early, so earlier than anything we saw on the left side. And I'll go ahead and play this now. You can see it still sort of originates there, and then it looks like it's actually going over Bachmann's from the right side to the left side. And the earliest side of the left atrium was sort of where you'd expect Bachmann's to insert, superiorly and anteriorly on the left atrium. And so after this map, or series of maps, was complete, I was pretty confident that the left atrium was not involved. The other thing that you should note is that the left atrium, as I mentioned before, was pristine. There was no scar there. And so, I have a ton of substrate on the right. I have no substrate on the left. So, I learned something here, even though the left atrium wasn't part of the problem. It was important to know that it wasn't part of the problem before proceeding. I don't want to just start burning randomly without really understanding, at least to the best of my abilities, what was going on with this particular circuit. So now the question becomes, well, where do I burn? And I'll be honest with you, I wasn't totally sure where to burn here. After thinking about it for some time, I'll come back to that, actually. Let me come back to that. So this is what happened, actually. So while I was in the left atrium, so we got that map. I was fortunately able to get a biatrial map, but while I was in the LA, I was moving around in the LA with the catheter, and then the flutter terminated. And then my face here is obscuring it. I'll show you on the next screen, but basically another flutter emerged, and that flutter was now no longer 370 milliseconds, but it was about 300 milliseconds. And so we have yet another flutter, concentric atrial activation. And so again, you got a map, and you can't quite see it here, but I suspected this might be CTI flutter. And when I entrained from the CTI here, now it was in. Now remember, all the other flutters that I had looked at prior to this, CTI was out. Now it's in. So now we're dealing with what was typical flutter. And actually, my catheter on the CTI terminated the typical flutter. And so I elected to do a CTI line. Once I did the CTI line, another flutter arose. This was at a cycle length of 370 milliseconds. So I suspected this was the very first or the second flutter that we encountered, where you saw early activation in the SVC. But I didn't want to make that assumption, so I remapped this. And the other thing that I did was I entrained from this area here, which is just adjacent to that sort of early area here, and just adjacent to very dense scar. This is the right atrial appendage. This is the base of the right atrial appendage. And when I entrained from here, I'm not showing you the electrograms, but I got a very good PPI minus TCL was about 0 with the same, what appeared to be the same atrial activation. So this region appeared to be in the circuit. Now, I didn't really see any good targets here, and I didn't want to just burn here. In fact, I think this area might have actually been not as good in terms of our entrainment results. But at this point, it dawned on me that even though there was essentially no electrograms here, I mean, the system, it couldn't resolve any signal in this area. It dawned on me that, I should start thinking about this case a little differently. Like when we're doing a VT, for example, that's structurally mediated based on scar, we know that the key areas for many of these reentrant circuits in the ventricle arise deep in the scar. We know that it's not completely dead, that there are channels of surviving cells that are often quite critical to sustaining that arrhythmia. And I thought, and again, I must confess, I don't normally encounter this in the atrium, but at this point, I had ruled out the left atrium. I have entrainment from this area here that looks promising. I have an early area, and so that's kind of adjacent to scar. So I reasoned that there could be a critical circuit that was taking place, within the scar that we just can't really see, much like we would see with a VT. There could be an epi component to the circuit that I'm not seeing, because we really hadn't mapped the whole cycle length. But what I did was I went into the scar, and again, there are no electrograms there, but I basically paced areas adjacent to this area of entrainment that was pretty good. And if I can capture with relatively low output in the scar, then there's surviving tissue there. It may look like scar, but it's not. And I found some areas right in here that captured and appeared to be within the circuit. I'm now at the base of the right atrial appendage. Obviously burning in the right atrial appendage is, you have to be careful. Certainly want to burn with high power, particularly on the free wall side where you could perf. But this appeared to be at the base, and there was thick tissue there looking on ice. And so when I burned in that area, we terminated 4 hours later. And so that was the second flutter that had emerged that sort of disappeared for a while. We encountered CTI flutter. This came back. And I think in the retrospect, basically this was a flutter that involved dense scar in the right atrial appendage. Okay, so that was the case. There was a lot going on. If I were to summarize it, I would say it was a short RP tachycardia that turned out, even though I initially thought this was going to be a run-of-the-mill SVT and possibly an AT that was focal, it actually turned out to be multiple macro-reentrant atrial arrhythmias, otherwise known as atypical flutters. There was one atypical flutter that was using scar in the crista region as a critical isthmus that we terminated with ablation. We then encountered a second flutter with a cycle length of about 370 milliseconds. That terminated with catheter manipulation in the left atrium, and typical flutter then came back, or didn't come back, but arose. We ablated the typical flutter. Then that atypical flutter that had appeared that showed a broad area of early activation in the SVC region, we confirmed that the left atrial wasn't part of that flutter, and then it really seemed to be arising. Some critical portion of that circuit appeared to be arising deep within right atrial scar in the right atrial appendage. Ablation there resulted in termination, and I couldn't induce anything else after that. I did try. So the take-home points for this case, I know it was a long case, but I thought there was a lot of good teaching points. You don't know what you have until you investigate it. I always say truth exists in the EP lab. If you want to know the truth about an arrhythmia, you bring them to the lab, and that's where you'll find the truth. We certainly can speculate and have conjecture about what this was based on the surface EKG. It's always fun to think about the different possibilities, but you confirm those hypotheses or disprove them in the lab. And what we thought we were dealing with turned out to be completely different. This was something that I really very few cases like this that I've experienced or encountered over my career. So you got to investigate. It's really important to be patient and systematic. It'd be really easy to get confused in this case. And when you don't know what's going on and it's not making sense, you really take the time to remap. Always look at your cycle lengths to see if things are changing. And it takes more time, it takes more time. But if you remap and you get something completely different, then something's off. You have to try to make sense of it. And then finally, don't forget about basic EP principles such as entrainment. Even though the technology that we have is incredibly powerful, it really does pay to go back to some of the basic things that we learned in fellowship about entrainment and otherwise. And in this case, the entrainment was really critical to understanding exactly what was going on. So I hope that was helpful. Thanks for tuning in. And again, if you like this, please subscribe to the channel. Please give me your comments and feedback. I will also put a couple of articles that I didn't mention here in the notes. Two in particular about how you might distinguish focal atrial tachycardia from something that's reentrant. There are a couple good papers on that. I didn't ultimately use those maneuvers, but it's good to know about them. So thanks again, and stay tuned for more content.